Hi and welcome back to another video of Medic Notes. This video is on esophageal carcinoma. Incidence of adenocarcinoma of esophagus in the Western world is now higher than SCC of the esophagus. Adenocarcinomas mainly arise in lower third of esophagus, often in region of Barrett's esophagus, whereas SCCs arise throughout the esophagus. Type of surgery depends on the position of cancer, but after resection a neo-esophagus is commonly formed from the stomach. Overall 5-year survival rate is 25% despite careful patient selection. Esophageal cancer occurs more in males, 3 times more than females. Common in older age people, and the common sites are lower esophagus and GOJ. For pathology, adenocarcinomas consists of 65% of esophageal cancers, mainly arise in lower third of esophagus and at GOJ. Predisposing factor is Barrett's esophagus. Squamous cell carcinomas can arise at any level of esophagus. Oat cell carcinoma is rare, with poor prognosis. Other rare tumors are adenoid cystic carcinoma, melanoma and carcinoid. For etiology, risk factors for adenocarcinoma include Barrett's esophagus, GORD, obesity, high fat intake, cigarette smoking, and high alcohol intake. Whereas risk factors for SCC are high alcohol intake, tobacco use, nitrosamines in diet, vitamin C and a deficiency, celiac disease, strictures, lye, webs, achalasia, and peptic ulcer disease. Clinical presentation. Patients may complain of dysphagia or odynophagia, retrosternal discomfort, atypical chest pain, pseudoachalasia, fluid regurgitation leading to bouts of coughing, aspiration and chest infection. Hoarseness, anemia, massive hematemesis, or lymphadenopathy. For diagnosis, upper GI endoscopy is the mainstay investigation. Other investigation for staging are EUS, PET scan or CT scan. Staging is based on TMN classification. For pre-op management, correct urea and electrolyte or anemia. Optimize nutrition by withdrawing solid food, starting high-protein liquid diet, and enteral feed via NG tube. Optimize respiratory function. Encourage stop smoking, intensive physiotherapy, treat any chest infection. Surgical approaches to the esophagus. Ivor Lewis procedure. An initial laparotomy and mobilization of stomach, preserving the right gastroepiploic arcade, followed by a right thoracotomy during which the tumor is resected and the mobilized stomach brought up to anastomose to the esophagus. McKeown 3-stage esophagectomy. This is an Ivor Lewis procedure plus a neck incision. The stomach is brought all the way up to the neck and an anastomosis is made between stomach and the cervical esophagus. Transhiatal resection, laparotomy and a neck incision. The esophagus is mobilized by blunt dissection from above or below. The stomach is used as a conduit and brought up to the neck and a cervical anastomosis carried out as in the 3-phase procedure. For post-op management, minimize pain, preferably using a thoracic epidural. Minimize respi failure, by careful patient selection. Pre-op physio, post-op intensive care, and good pain control. Also minimize post-op nutritional deficiency using a feeding jejunostomy. That's all for this video. Thank you.